Welcome to this edition of The Boundless Brain. I'm Hoppy Kirchhoff. Epilepsy is a neurological disorder characterized by recurrent seizures that typically begin in childhood. It's one of the most common neurological disorders in children, affecting an estimated 1 to 2% of the population under the age of 18. Epilepsy can be a challenging condition for children and for adults. Early diagnosis and treatment are crucial for improving outcomes. Joining me to talk about this is Dr. David Adelson, Vice Chair of Rockefeller Neuroscience Institute and Director of WVU Medicine Children's Neuroscience Center. Doctor, welcome. Good to see you.
Thank you, Hoppy. It's great to be here.
Good to have you. What is epilepsy?
So, epilepsy is a chronic condition of a patient whose brain is unfortunately dysfunctional, sort of firing when it shouldn't be firing. So, we know the brain is always electrically active, but what happens with epilepsy is that there's abnormal electrical activity. It's kind of like sparking. And what happens with a seizure is that basically those sparks come together and spread across the brain. And so that's a seizure. It becomes one in which there's a loss of consciousness. Sometimes there's movements that are associated with it. Just depends on where the seizures are originating from and how they spread.
So they can originate in different parts of the brain?
That's right.
Why?
They do. Well, it just depends. It depends on whether there's an underlying abnormality like a brain tumor or a vascular malformation. But unfortunately, some people are born where the parts of the brain didn't form properly. And in those areas, what we call a cortical dysplasia, those can become origins of seizures. And then seizures then spread or become chronic. If you have more than one seizure, then you have what's called epilepsy.
Is it important to know exactly why a person has epilepsy? Do you need an exact diagnosis?
It is. It's very important. And it's one of the things that's often overlooked is that sometimes it's been poo-pooed as in, oh, he just has seizures or he just has epilepsy. But the reality is that in some cases, it can be associated with a low-grade brain tumor or a vascular malformation that may be leaking blood. And so it's important to try to figure out what the origin of those seizures are. And is it a growing or a becoming a big problem kind of issue, or is it something they were born with, and is it something that we can address? We know that it's very important to define where the seizures are coming from because we know that it's more dangerous to continue to have seizures than it is to undergo the treatment for them.
And we're going to get to treatment. Are all seizures related to a form of epilepsy?
So epilepsy is a chronic disorder of somebody who has multiple seizures.
Okay.
So having a single seizure, let's say there are very young children who have a febrile seizure, does not mean they have epilepsy. But if they have repeated seizures, then they get diagnosed of having epilepsy.
Is epilepsy hereditary?
It can be. So one of the things we're learning is that there can be a genetic component to epilepsy. And so there are some genetic epilepsies that need to be defined because those treatments are different than they would be for someone who has a tumor or a cortical dysplasia. I
know, doctor, that you all have come a long way in understanding epilepsy, but where do you think you are on the scale of really fully understanding why the brain does what it does?
Well, I've been doing this 40 years, and so I have to laugh because when we used to do our diagnosis, it was very, very primitive. So I look at where we are now and say, man, we've made a lot of progress. But one of the things that when you've been in the business long enough, it sort of feel like the more you know, the less you know. And so, for example, this whole genomic component has really come on in the last 5 to 10 years. And while we knew that there could be some genetic reasons for having epilepsy, until we started to be able to define these specific genes that were causing the brain to be abnormal or to fire abnormal and function abnormally, then in those instances it's been sort of an amazing revelation, and with that has come different treatments. And so that's what's been exciting about being in the field.
How far along are you in fully understanding the genome aspect of this?
Oh, we don't know hardly anything at this
really?
point. Yeah, it's amazing. we talk about epilepsy as being kind of this focal versus generalized, and we used to just group everything as generalized of pretty much what we didn't understand. And now we know that there's genetic components. We now know that there's electrophysiologic components. There's a whole connection issue that we are just now starting to understand. And so that's been part of the fascinating part in my career, has been able to see this evolution in our understanding of, where has epilepsy been, but now where do we see it going?
Is epilepsy really almost an umbrella term because there's different kinds of epilepsy?
That's a great way to put it. Yes, some people call it an umbrella term. Some call it just the great wastebasket of epilepsy or seizures, spells, everything like that. But I think as we learn more and more about what causes the brain to dysfunction, then we start to be able to better group these patients into their appropriate, for lack of a better word, categories. We call them phenotypes. And with those phenotypes, now we can start to get better ways of making the diagnosis and then coming up with unique treatments, novel therapies for those patients.
Let's talk about childhood epilepsy. And what should parents be looking out for? I would think there are obvious instances. A child has a seizure, passes out, whatever, but then there are probably more subtle aspects, or not? I mean, what should parents be looking out for if they think maybe there's a seizure issue?
Yeah, so what we're looking for are repetitive behaviors that seem to be frequent or becoming more frequent. So there are some children who might present with just the hand moving, face twitching, staring spells where you can't seem to snap them out of it. Those are all potentially seizures, and if it happens once, it's probably not related to anything. But if it was happening, let's just say once a month, and then it became once a week, and now it's happening kind of every few days, now every day, that becomes a little bit more concerning. And those would be things that you would look for. Mm-hmm. Unfortunately, many infants have what's called subclinical seizures. So they have the electrical abnormality going on, but they haven't built yet the neural connections to show it outwardly of what's going on. And so some of them are having seizures and we don't even know it.
Really?
Yeah.
So it'd be very difficult to diagnose then.
Those are very difficult to diagnose. Sometimes they come in because they just are having, let's say, repeated spitting up or vomiting or seem unresponsive. And then they come in and we hook them up to EEG or an electroencephalogram, and we can actually see the abnormal electrical activity going on.
So let's talk more about that. So let's stick with children, and they bring a child in and you say, yeah, we better look at this. Then can you pretty effectively diagnose what is going on?
Well, no, it's actually one of the things about epilepsy is that it is often very difficult to diagnose. And so, yes, we do know that if you have abnormal electrical activity on the EEG, and you have what looks like a seizure that correlates to that, and they have it more than one or two times, then now we're talking about someone who has epilepsy. Mm-hmm. Then we go into, now we start to do imaging because we're looking for an anatomical abnormality. So we're looking for a tumor or a vascular or a dysplasia. On the other hand, now with more modern technology, we can actually start to do what's called functional imaging. So we can actually see where there are abnormal parts of the brain that are not functioning well. We know what the normal metabolism is of the brain. Now we can actually image that, and when we see that there's, let's say, areas that are not metabolically as active, or when they're having an abnormal activity, and now we see an increase in activity in a location. So these are some of the subtle ways with imaging that we're now starting to be able to pick up where those seizures might be coming from.
And that certainly will lead to the kind of treatment that you do. When you discover these things through analysis, how do you have that conversation with the parents?
That's a great question. So, a big thing that we want to do is to get to the bottom of why they're having the seizures. And so that's oftentimes the EEG. We would admit them to the hospital. We have a video camera on them while we're recording the EEG so that we can see these, maybe let's say, quirky movements or behaviors or staring spells, and then look at the EEG and see timestamp-wise what's going on. Mm-hmm. Similarly, when we have the imaging, maybe we can point out the spot that's causing the problem, or a larger area that might be a problem. So when we have this conversation, what we're saying is that we can see where the normal areas of the brain are. This is an area of the brain that's not normal. It's an area that's contributing to these problems and will go on to cause problems further for your child in the future. And so we want to be aggressive in the treatment of that child.
Aggressive, what can you say or do you say that you're comfortable with in terms of reassuring them? Mm-hmm. Because that's traumatic.
Oh, absolutely. It's often a very traumatic diagnosis for the families. There's often in our society, unfortunately, a large stigma, and so it's kept hidden. A lot of times some of these children, are kind of kept under wraps because, they don't want to share that. Some people in the older days thought it was something that they could catch, like an infectious disease. And so there's a lot of these sort of old stigma. It used to be thought that they were witches, people who had seizures and were,
some sort of demonic presence.
Exactly. And that Satan was taking them over. And so, we've spent a lot of time advocating for children and adults with epilepsy because of that stigma, and to bring it to the forefront. Now, there's lots of people who have epilepsy who are functioning quite fine, and they're controlled on medication, and that's all they need, and they can do regular jobs and get around and drive, especially if they haven't had seizures in a year, then they can get their license and stuff. It's really for the other children and adults who don't respond to, let's say, first or second line medication. Those are the ones that we're most concerned that will go on to develop what's called medically intractable epilepsy. And then those are the children and adults where we have to be even that much more aggressive with their treatment because we know that it's much more dangerous for them to continue to have seizures than to undergo even more aggressive treatments.
And is that where you use laser ablation?
Sure. Laser ablation is one of those kinds of treatments. What we're really trying to do, laser ablation and what I would say the old days when I was in training, was that if we could identify a very targeted area where those seizures were coming from, we could do an open surgery and remove that area. What's been fantastic about growing up within this disease disorder and learning to understand it better is that we've been able to develop technologies where we don't need to do open procedures as much. And so many of the surgeries that I used to do as a open situation where they'd have to go into the ICU and be there for a few days and then be in the hospital a number of days and then take weeks to months to recover. Now we can sometimes do this with a much more minimally invasive approach where the patients go home the next day and they have a much smaller incision in those instances. So laser ablation basically has removed the need for doing, in some cases, open surgery because we just place a laser probe in the area where we think the seizures are coming from. And what we do is heat that area using the MRI as a guide for seeing how high the heat is going. We create safety points so that we don't heat beyond where we want to heat. And then what we can do is we can ablate or melt an area of the brain that we know is abnormal. It's not contributing to function. So, these patients aren't any different afterward. But the hope by doing it that way is that we can stop their seizures.
Here's a non-medical term. It sounds scary.
Yeah. Well, it is.
Because you're opening it. I know it's minimally invasive, but you're opening a part of the skull. You're inserting into the brain and trying to reach a particular point.
Well, in the old days, as I said, let's use temporal lobe surgery, which is where we would make an incision that would be a question mark. We'd move the muscle, the bone, and get down to the part of the brain that was causing the seizures. Now we can make a 3 millimeter incision, so it's 1/10 of an inch, where we just pass the probe to the target and then be able to withdraw that laser and be able to ablate that same area where we would have had to pass through normal tissue just to get to the abnormal tissue.
So you're reaching that area which you've determined through MRI, right, or through mapping, and you're destroying those cells, or
yes, or you're heating them up to a point where they would basically die and then scar over. So that's one way that we can do that. And another type of treatment was in patients who had very, very severe epilepsy where they would suddenly drop. That's what's called atonic seizures. It's often associated in childhood epilepsies with what's called Lennox-Gastaut syndrome. Those patients, we used to do what's called a corpus callosotomy open, and that would be a surgery on the top of the head, go between the brain hemispheres and split the fibers so that they wouldn't go off at the same time. Well, now we most often, 90% of the time, can do it with a laser where we just place the laser probes and be able to do that disconnection without having to do an open procedure. Those patients, when we did it open, were often in the hospital 10 days to 2 weeks. Now they're in the hospital 1 to 2 to 3 days. That's all. So
what is the success rate?
So for the success rate for open surgery is going to be a little bit better than with the laser, because it's not as, even though it's minimally invasive, it sometimes doesn't heat the way we want it to heat. And so,
why is that?
And that's because the tissues propagate the heat in different ways, and so there's often cooling from surrounding blood vessels, from the cerebrospinal fluid, and so we can't be as accurate as if we did it under direct vision. Now, it's less invasive, but there is a percentage of patients that don't respond, or we don't get all the spots we want to get. And so in those instances, excuse the pun, we haven't burnt any bridges. We can always go back and place another laser probe in an area that we maybe missed or didn't ablate as much as we wanted to. So I would say, though, with temporal lobe surgery is a great example. In those instances, 90% of patients we could cure.
Really?
Of their epilepsy. And so with the laser ablation, we're seeing that in maybe 70 to 80+% on the first go around. But when we go back and see that, well, this is an area that maybe we could reheat, or maybe this is an area that we didn't target originally that we missed, maybe we should go for that area. Those where we can really jack up those percentages up to 80 or 90%.
Tell me a story or stories about a patient whose life was impacted dramatically by epilepsy. Then they have this procedure and it's hopefully life-changing. Do you have those stories?
Absolutely. I got lots of those stories, which is just amazing. I remember a young woman who came to us. She was 14 years old, and she had non-dominant hemisphere right temporal lobe epilepsy, and she seemed very gung-ho. I don't want to live with this. I want to be able to drive. I want to be able to do outdoor activities. But the parents were scared, using your term, and they would not allow her to undergo any surgery. And she showed up in my office at 18 years old, 1 month, and said, now I'm ready. I can consent for my own surgery, and I want the surgery. And we did the surgery, and 6 months later, she ran the Chicago Marathon, and she became a whitewater rafting guide, which she couldn't do if she had epilepsy. And so that was a story that always brings a laugh and a tear to my eye, because it was obviously life-changing for that young girl. But again, I completely understand parents being scared. Brain surgery is a scary thing, and we do take it very seriously, but it's one of those things that can be amazingly life-changing for these patients. And we recognize that, interestingly enough, it's again, and not to beat this down to a dead horse, but that it is much more dangerous to continue to have seizures, because you can have what's called SUDEP, which is sudden unexplained death of epilepsy. And that's one where children go to sleep and never wake up. Adults too, don't want to underscore that. There are times where people go into a bathroom and have a seizure and then hit their head, or fracture something very important. Sometimes they're not found right away. Or they're in a bathtub and they drown because they had a seizure and weren't able to get themselves out of it. So we do know that in my 40 years, I haven't had any patients pass away from epilepsy surgery, but I've had patients who passed away who were still having seizures that we hadn't gotten to.
Do you feel compelled as a provider, do you feel compelled to try to talk them into having the surgery, or you just present the information, and if the parents are reluctant, for example, say, well, that's your decision? Where is the line for you in advocating for the patient but respecting the wishes of the patient and or the parents? What's that line?
That's a great question, and that's one, I often get questions from from families, if this were your son or daughter, would you recommend it? With every treatment, whether it's medicines or surgery or alternative treatments, you have to weigh the risks and the benefits. And, if it was a situation where I thought something was a very high risk and now we're at a 50-50 level, that's one that really the family should take into consideration, that maybe this is this for us or not, or can we live with this or not, and those kinds of things. What I would say is that, again, I try to present the facts. I try to present what's the likely expectations, because we're not going to be able to cure everybody. The laser ablation is a great example. Those are very targeted epilepsy syndromes where we can ablate an area we know is causing the seizures. But there are many patients who have, let's say, intractable epilepsy that's more generalized. And so we don't have a place where we could do a laser ablation or a disconnection and expect that they're going to really be markedly better. Those are instances where we're doing neuromodulation,
which is
where we try to interfere with the seizure activity within the brain. And there are multiple modalities for that.
Is that because it's coming from different parts of the brain?
That's right. Okay. It could be coming from different parts, or that the whole brain itself is abnormally connected and tends to seize in a generalized fashion. And so there are a couple of different modalities, and one of them is vagus nerve stimulation. And so that is a very, very low risk procedure. It's basically like another medicine, because their neurologist will be able to control the dosage and the frequency. And it's something where it's a 45-minute procedure and you go home the same day. And we know that the medicines themselves can have a significant impact on the brain. And so I really highly recommend that device for someone who's kind of scared or afraid of brain surgery, because that's a great entry-level approach toward trying to get control of the seizures. And many patients have just had great outcomes with that device, and it's one that they can do their normal activities and go on with their life. The more invasive neuromodulation is when we're starting to place electrodes into the brain itself. And again, it's still safer than still having seizures, but the outcomes, we're not curing the seizures, but we're trying to interfere with the abnormal electrical activity.
Manage.
Exactly.
Manage.
I had a young girl who was having 6 to 10 seizures a day, and it was just interfering with her ability to go to school and to enjoy her activities and her quality of life. We put in what's called a responsive neurostimulator, where it would read where her seizures were reading her seizures and giving her a stimulus. And so we saw that she was still having the seizures, but now they were not stopping her from being able to do what she wanted to do, because it interrupted the seizure propagation, so the spread of the seizures to the rest of the brain. And so now she was basically seizure-free in that it wasn't interfering with what she was doing. She couldn't come off medicines, but now she didn't have to be on so much medicine. So she wasn't so sleepy or so kind of like drugged up. And now she was able to do activities with her siblings, with her friends, and really go on to a more normal life. Even though we didn't cure her seizures, we clearly improved her quality of life.
Do you see, and obviously, as you mentioned, the treatment's come a long way in a relatively short period of time. Do you see a period in the not too distant future where the technology and the treatment is even better, that you make, even more significant progress in treating epilepsy?
Yeah, I mean, that's what's been so fantastic about being part of this career is been that about every 2 to 4 years, I have to retrain on a new technology because it's growing in so many different ways. And so I do, I'm hoping to continue to relearn new technologies, whatever we can do to bring better diagnostic accuracy to our being able to tell families where their seizures are coming from, and then novel treatments that we hope to bring here in West Virginia and across the U.S. and around the world, to these patients that are truly suffering.
Concerning West Virginia, you're from Long Island, you're from New York, you've been in Los Angeles, you've been in Boston. Here you are in West Virginia.
Yeah.
Why are you here?
Well, one of the things that I've always enjoyed or appreciated in my career is the opportunity to be involved to treat patients from underserved populations. And so being in Arizona just prior to this, and now really coming to West Virginia where there was a huge need. There really was not much of an epilepsy program. And, if I could kind of talk up a little bit, my first major job out of training was in Pittsburgh. And honestly, we used to pride ourselves on being able to draw patients from West Virginia. And now I'm very proud of the fact that we now kind of created the direction in the other way. So being able to develop and create this type of Children's Neuroscience Center, which really looks to treat these type of children with epilepsy and other neurological issues, that was a great opportunity that the leadership here at WVU offered to me, and it was a great opportunity to build something from scratch again that was going to be, I think, hopefully a long-lasting legacy.
You feel like you're making a difference?
A huge difference here. I think medical literacy is rising. I think we're bringing much better quality of care to the children and adults here in West Virginia, and it's great to be part of the Rockefeller Neuroscience Institute because through Dr. Razai's leadership and Dr. Marsh and Wright, all of these people have really contributed to the growth of neuroscience within our community, and really created cutting-edge diagnosis and treatments for patients that didn't exist here 10 years ago.
Thank you, Dr. Adelson. If you'd like more information about treatments for epilepsy or the groundbreaking work being done at the Rockefeller Neuroscience Institute, go to wvumedicine.org or just Google RNI. For our producer, Chad Poche-Adkins, I'm Hoppy Kercheval. Thank you for joining us on this edition of The Boundless Brain.